Welcome, everybody. This is the Rotary E-Club of Silicon Valley, and every week we bring you the stories of people who are making a difference in the lives of others locally, globally, and digitally. We're part of Rotary International, over 1 million people in 36,000 clubs around the world who subscribe to the idea service above self, the joy and meaning that comes from helping others. And especially if you're doing it in interesting, innovative, sustainable ways, that becomes all the more interesting to our group, the Rotary E-Club of Silicon Valley, which is an international crowd because we are both online and asynchronous, which allows for tremendous flexibility for people who have a heart for service, but may not be able to join a traditional club for any particular reason. Our speaker today is joining us from Guatemala, and it is exciting to hear about the innovation brought to an activity that has always been around, childbirth. And what it is that there are people in different places in Guatemala who might want to have a midwife be there for the delivery of a child. And the question is, what happens when there's an issue? And when we're dealing with language issues and distance issues, what would be the innovative way to address these ideas? And I am really excited that we've got Ann Kramer to talk to us about the work of her organization and the app that they are using to make great things happen for people who otherwise would be in very difficult circumstances. So with that, I'll hand it over to our speaker, Ann Kramer. Welcome to the Rotary E-Club of Silicon Valley.
Great, thank you. Hello to everyone, and it's wonderful to be here today. Thank you so much for having me. I'm going to share some slides mainly to show some pictures and help you jump in to understand a little bit more about our work. Oh, 1 second, let me grab that. Okay. So I'm from My Health Alliance, or Wuku Kawok, and we are based here in Guatemala. I'm one of the co-founders, and just to give you a little bit of background about the work that we're doing, we've been working here for 18 years, and our mission is to transform health and build equity across Guatemala. We work in 9 departments across the highlands of Guatemala. We have over 130 staff members, and of those staff members, 95% are Guatemalan and 80% are Indigenous. So that's really key to the work that we do, because here in Guatemala, unfortunately, the main challenge is that Guatemala is one of the most unequal countries in the world. While it is one of the wealthiest in Central America, it has a big disparity of wealth within the country. And often women and children of Indigenous descent suffer the brunt of that poverty. Things like different languages, because we have 22 different Mayan languages spoken here, plus Spanish, distance, cost, not having enough money, mistrust in the healthcare center due to civil war and racism and things that have happened here in Guatemala, many women and children suffer. We formed our organization to provide and build capacity with health workers here in Guatemala. So on our team, we have a majority of women nurses, women healthcare providers who are going out and into the community. And with our work, what we're trying to do is really bring culture and language and healthcare together. Because when we can meet someone where they're at, when we speak their language, when they can understand what we need for them or what we can understand them, we can have really better health outcomes. Unfortunately, Guatemala suffers from one of the highest maternal mortality rates in the region. And so we thought, how can we solve that? What does that mean to solve for that problem here in Guatemala? So when we met with midwives and we really dig in and understand the culture and the community, we realized that a lot of women, they want to birth at home. They feel comfortable at home. They speak a Mayan language, and going to the hospital is scary. Oftentimes they tell us, if I go to the hospital, that's where you go to die. That's where I'm left out in the hallway. In fact, I've had patients tell me, I'd rather stay at home and die than go to the hospital. I mean, that was so impactful to me. What do you mean you don't want to go to the hospital? You don't want to have someone to care for you. But they said often they don't speak our language or we're not well treated. I'd rather be at home. So for women who are birthing at home, how can we save their life if there is a difficult situation? So bringing culture and technology together, we co-created a telephone app that basically helps midwives detect a problem during or before the birth. And then we provide care navigators who are in the hospital to solve for the hospital problem, basically speaking their language, being present with them, helping them to make decisions, talk with their provider, and our outcome is to help and save lives for women and children. We started this work in 2016. So with midwives, we co-designed a telephone app based on Android phones. We were the field implementation, and we worked with our partners at Emory University. And working with a group of 40 midwives, working in their language of Kachikal Maya, we met with them and co-designed this fantastic app that helps them save lives. We've learned a lot working with midwives over time, because a lot of them don't read or write. They've been trained traditionally as, someone who learned from their mother or learned from an aunt on how to be a midwife. They also have classes with the Ministry of Health, but oftentimes it's in Spanish, not in their own language. So we've learned that we need to work with them in small groups. We need to train in their language. We need to share experiences with them. And here in this photo, what you can see is midwives learning on how to do how babies breathe, basically working with them in their first minutes of life if a baby's not breathing. The mobile app and equipment that we co-designed with the midwives was basically to create a picture-based application, something that a pilot might use before takeoff. It's sort of like a checklist to run through all of the things before you take off. So the midwives are running through high-risk problems for their patients. They also have a blood pressure cuff, they have a pulse oximeter, and they have a Doppler in order to listen to the baby's heart rate. They have 4 visits that they can choose from the application: a prenatal, perinatal, postnatal, and neonatal visit. So this is what the application looks like. As you can see, the pictures are really easy to understand. They were drawn here in Guatemala. The midwives helped us design and understand how the application is. The application is all picture-based. There's no words. It's easy to choose yes or no. And the big speaker button in the corner speaks to them in Kaqchikel, so that everything is done in their language and it's really easy to understand. So the midwives are going to see if the mom has, blurry vision, if she has any bleeding, if she has swollen feet, headache, all of those high-risk signs that they might need to go to the hospital. Our staff is standing on call 24 hours a day. So we have 40 midwives attending their patients in rural communities, sometimes 2 to 3 hours away from the hospital. And the midwives go and visit their patient. And if a high-risk problem is detected, it goes immediately. The application calls our 24-hour team on staff, and we help overcome and reduce barriers such as transportation, getting the woman out of the community. And then our care navigators are standing by to help be with them, to overcome delays in hospital referrals, to speak with the doctors directly. Our care navigators are in the OR if there is a cesarean. They're with the woman the entire time she's in the hospital. They're there to communicate, to support, advocate, coordinate, and translate. As you can see, this is one of our care navigators who speaks Kaqchikel and Spanish, so she can easily coordinate with the Ministry of Health as with our patients. And in Guatemala, an interesting fact is that there is a law from 2012 that says women should have someone with them in the hospital when they birth. Unfortunately, that's not the practice. The Ministry of Health hospitals do not let women have anyone in the hospital with them, so they go and birth alone. Who wants to birth alone? So the care navigators are really key to this piece. We have technology, but we still need that human piece to translate, be with them, hold hands, advocate, call the family back home, let them know what's happening. Our impact since 2016, when we started this as an NIH research study, is that we've had 6,333 total deliveries, over 4,000 hospital visits, and we've increased our number in hospital births, and we're very happy to report a reduction trend in maternal deaths. We have a very close working relationship and collaboration with the Guatemalan Ministry of Health, and we have ongoing training with midwives. In 2016, right before we started this study, there were 8 maternal deaths in the region where we're working, which is very high. I'm very proud to report that since that time, we've only had 4 since 2016 to date, which we're very proud of. Our mobile health team, as you can see, is majority Indigenous women, which are leading the fight to save women's lives. And they're very proud of the work that they're doing. They're speaking Kaqchikel, and they're really excited about the next steps that we're doing right now to expand and start to scale this program. When we look back on 2024, something that's interesting is that we have still a higher number of facility births, but still 57% of our births in 2024 were in the home, showing that women still prefer to birth at home. But we're very happy that 43% of our births were in facilities and women felt safe to give birth there. Something that we're really proud of is the data that I have through now is from January to October of 2024. We can say that because of our work, we saved 23 lives. And how did we save those? Because of our timely detection, getting women to the hospital on time, we were able to avoid hemorrhage, preeclampsia, uterine autonomy, and placental retention. These are things that otherwise, if the woman would have birthed at home and she didn't get the hospital on time, she could have died. So we're really happy that we can track all of this data, that we have all of the information on our patients. We're sharing that in time with our doctors, our nurses, and the hospital. Something new that we're working on, as you work with midwives, as you work with moms, there's babies. And something that we've learned through our time since 2016 is unfortunately there's a very high neonatal mortality rate here in Guatemala. And as we've been trying to understand the neonatal mortality rate, we've realized that about 30% of newborns in 2023, when we were really tracking closely, were low birth weight. And many of the babies who are born at home, their critical mortality period is during the first week of life. So we were trying to really understand, why are baby dying at home? What is happening when they're dying at home? Because unfortunately, when babies are born at home, sometimes they're not even recorded that they passed away. Most often, after a baby is born, they're not put into the federal system to have a name and a birth certificate until about a month after they're born. So we're really trying to dig in, understand, work with moms and midwives, and it's really difficult. A lot of people don't want to talk about this. It's a very difficult subject. So we've been doing a lot of interviewing, talking with moms to understand what happens. Why do babies die? And we're really trying to understand that low birth weight situation. We're also working with midwives to enhance their neonatal resuscitation skills. So some of the things that we're doing right now around improvements to our program is, one, we're trying to get into homes for neonatal screening and understanding babies and how they're doing in the first 3 days of life. That's one key feature. Another key feature that we're doing is working on improvements for our Safe Natal application. So this application that we created in 2016 has been very successful, but we see where improvements are needed. So one of the aspects that we're working on is the digitization of blood pressure. Our partners at Emory University are working on helping us to upgrade the app. Also, since 2016, we've been recording fetal heart rates. And what we've been trying to do is understand intrauterine growth restriction. So what's happening during the pregnancy? What's happening? Why are babies born with low birth weight? What's happening to the mother? Overall, we want the best health outcomes for mom and baby. So currently we have an NIH R01 research study that's trying to really understand the fetal heart rate and the birth outcomes. So that's something else that we're updating the app, that it should be able to automatically understand and know what the fetal heart rate is. And that will help us make timely decisions with the midwives for best birth outcomes. We're also improving the Doppler for listening to the fetal health outcomes. So when we're working in houses that sometimes don't have electricity, that are very far into the mountains, we have to be really thoughtful about the applications, about the materials that we're using, because we don't always have electricity or we need to have batteries on hand. So it's really key that we're really thinking about light, things that are easy to travel with, and things that can be very durable. So new challenges that we're going through right now is that we're expanding our program to go from 40 midwives to 80 midwives. And usually we're attending about 1,000 births a year, and we're going to double that to about 800 to another 1,000 births per year, providing neonatal visits within the first 3 days after birth, educating mothers about breastfeeding techniques and kangaroo care, and continuing the dialogue with healthcare services regarding culturally relevant care. So that's what we're doing here in Guatemala, and we're really proud to share this with you today. So thank you.
Fantastic. Wow. So many interesting things to explore with this. Before we get to the questions and answers, I'd like to introduce the group that we have on the recording. So when I call your name, absolutely wave at the camera, that kind of thing. In Houston, Texas, Rory and Gus. All right. And here in the Bay Area, we've got Elton. We've got Christopher. I am in San Mateo. We have visiting in California from South Africa, Karika Cass of Parklands College, and our club treasurer in Italy, Cecilia Babker. All right, Anne, let's start with a question that came in through the chat, and that is this: when you are talking to people about the work you do, where are the areas that you need help? What are the kinds of things that you look for in terms of partnerships, and what kind of challenges are you working to address through your partners?
Thank you. We're definitely looking for people who have new ideas around technology use and healthcare. So that's something that we're always looking for partnership is what devices can be used in these rural conditions that can really provide quick responses. Because sometimes getting people to hospitals, getting people to laboratories can be difficult. So people that have ideas that have new technology around using healthcare devices in the field is fantastic. We're always looking for people who are willing to learn more about our work and who are interested in donating and partnering with us over the long term. We're really excited because of a new partner, we're able to double our program. And so because of the Patchwork Collective, a new partner, we're doing this doubling and scale up. So hopefully we can test and be able to work in new languages across Guatemala in the future. So people who are really interested in looking at maternal health, women's health through the lens of culture and language, and how do you really meet patients where they are?
Nice. The connection to Emory is clearly a critical piece of how things work. Can you describe that in a little more detail?
Yes, definitely. So Emory University and the lab of Dr. Gary Clifford, we've been partnering with them since 2016, and they're fantastic at creating the applications of really thinking through the technological side of things. And we've been doing all the field testing and, doing a lot of back and forth. And together we've created the Safe Natal app. And from there, right now, we're really looking at how we could use artificial intelligence to improve the application. So basically, by new phones that are out now with, more technology, what we're trying to do is with the help of Emory is to be able to use the phone to understand the fetal heart rate to let us know how the baby's doing and quickly with artificial intelligence let the midwife know if they need to be more concerned than the traditional high risk pregnancy problems that they should be looking for. So this is upcoming. We're doing this study right now, and it's very exciting. And we're really grateful to our partnership with Emory in order to make this happen.
Nice. One more partnership question before we get to the app, and that is about Rotary. Have you connected with Rotary groups in Guatemala as a part of the work you do?
Yes, we're really proud that we've partnered with several Rotary groups in the United States, Canada, and Guatemala. We've had a global grant, actually two in the past, in order to do, one was around clean water treatment, and one was in malnutrition and community gardens. And so we've had a fantastic partnership with Rotary over 18 years in order to do a lot of great work in our communities.
Nice. Let's shift in a new direction. Elton, I know you've got a question or two. Go ahead and unmute.
Yeah, I'm Elton. I'm the podcast manager for Rotary, and my daughter worked for Anne for a year when she graduated in college before she got her master's in public health. Um, so I'm an old app developer, and when I look at your app on your website, the little 6-minute video you have, which is so good. It occurs to me that simply swapping out the Mayan audio files for, you know, Afrikaans or whatever, any language, it could be fairly quickly used other places. Has the app been used by other organizations or in other languages? And if you run into any resistance with midwives feeling like their job is being stolen from them?
Great question, Elton. Thank you. And yes, we loved having your daughter with us. It was fantastic. And what's really interesting is Emory is currently piloting this app in Tanzania. And so they've been using this app, just getting it started to see how it will work in a different context. And we're giving our advice and our learnings. So we're going to see how that goes. And here in Guatemala, we discussed it with other midwives who are Quiche speaking midwives. And they came and witnessed some of our midwives working with the app. And a couple of them said, I don't know. I feel like I'm a machine. I'm a robot. I don't know if this is something I would want to do. And the midwives discussed it a little bit, and they seemed more open to it when our midwives said, this is just part of the process. We still do our traditional visit, our traditional massage, all of those things that continue a longer visit that the midwives do. And that they said, this is just kind of a tool in our pocket as being a midwife that helps us make sure our moms are safe. And so I think that helped the other midwives be a little bit calmer about feeling like a robot. So we hope to expand into other languages in the future because, as you said, it's so easy just to swap files.
I love that. That actually is in a space of question about languages that was in my head as you presented. How did this initially happen? We're talking about language barriers on multiple levels. So if you guys are trying to connect with the right people in Guatemala who are the right people to connect with the midwives and for there to be trust among everybody, tell us a little bit about languages and how you work with languages to make the organization successful.
Yeah, languages are really important. A lot of people think Guatemala only speaks Spanish, but we currently work in 6 languages, Mayan languages plus Spanish. And it's been really key to be able to dig in and really have people speak from their heart who they are, what their health problems are, what their health problem that their child has. And even though here sometimes it seems someone might speak Spanish pretty well, like a woman from the community, but when you want to dig in about health problems, about concerns, it's really hard to do in a second language, sometimes a third language. And if your healthcare provider does not speak your language, you're always missing something. And so for us, it's absolutely empowering to speak the language of our patient. And so our nurses, our teams come from the communities where our patients are. So they speak the language, they understand the barriers our patients are facing. And I think together with all of those pieces, with language, culture, medical care, the research that we're doing, we have excellent healthcare outcomes. And I think that's absolutely ideal for our patients.
Well, it also seems that you value the experiences of the midwives in their traditional roles, which seems to be the underlying piece of success for so many partnerships that happen in terms of service in places. What are some of the things that you personally have learned from the midwives as a part of the work you've been doing there for these years?
It's a great question. I was just in the field recently with one of our midwives, and she's really funny. I was asking her how she became a midwife, and she told me, well, it came to me in a dream when I was about 23. And most midwives feel this is a calling, something that they need to do with their lives. And she said, I kept having this recurring dream that I was going to deliver babies and that I needed to do this. And she said, my mother-in-law was a midwife, but I didn't really feel like I could learn from her because she was my mother-in-law. So I trained with some other women, and she said, I just began delivering babies, and I've been delivering babies now for 28 years. And then she told me that she delivered her own baby because another midwife didn't show up on time. I mean, the fortitude, the strength that these women have are incredible. They're called up at 2 a.m, 3 a.m. They walk up hills, in the middle of the night on foot, all over the place. They're really incredible women who I've just learned so much from about strength, about, when you think you can't, you really can. So I really admire these women.
Finally, a little bit about the villages, the cultural environment in Guatemala. When people are thinking about Guatemala, when they're thinking about rural Guatemala, what are things that they often don't know that they really should, that might surprise them?
Yeah, so I think there's a transition happening in Guatemala, especially in the rural regions. Most people have been subsistence farmers for a long time, growing corn and beans. Corn is a really key part to who the Maya people are. But over the last 10 years or so, there's been a lot of change toward industrial agriculture. And so a lot of people are now growing things such as broccoli and snow peas, carrots, things for export. So that's definitely changed sort of how people's lives are. It's also, I think, tied them into the international community more. A lot of people have gone to the United States in certain communities. You'll see that there's a lot of new homes. They might have people in the US who are sending remittances back. And then you'll go to a community that are very traditional adobe homes that don't have bigger, more fancy homes. And so they're a community that doesn't have a sending culture or sending community. So it's been really interesting. I've been here for over 20 years to see this transition that's happening in rural Guatemala. You're also seeing people being able to quickly relate to what's happening in the United States or across the world because of the change of technology. Everyone here has Facebook. That's really the main social media form, Instagram and things as well. But it's been incredible to see this transition since I've been here of people having phones, people having direct instant information worldwide and not just locally on the radio, which was usually the mode of transportation and information since I came here about 20 years ago.
Well, you guys are doing amazing work, and it is such a pleasure to be able to share your story. In a minute, I'll hand it back to you, but I'd like to say to everybody who has joined us for this recording, thank you. Thank you for taking your time to hear the stories that we are so privileged to share as part of the Rotary Club of Silicon Valley. All of our members are absolutely encouraged always to look for these incredible stories that happen in their lives, the lives of their loved ones, like Elton's daughter getting a chance to be part of Maya Health Initiative as well. So the opportunities that we have to find out about and to share stories, it's very much a part of what we value being in Rotary and being part of this club in particular with its incredible flexibility. As we always like to do, we hand it back to the speaker for the final word. So Anne, in terms of what somebody might be thinking as they finish listening to the podcast or watching the video, what would you like to make sure they have clearly in mind?
Thank you so much for having me. And I would say the importance of language and culture in medicine is absolutely fundamental. We can really reach people and really change lives when we can understand where our patients are from. And so thank you so much for letting me participate today. It's been wonderful to be here with you.
Excellent. Thank you. And we will see you next week.